Good morning, everyone. I am Dr. Emmanuel Jackson, and I'll be taking MRI brain anatomy this morning. I'm a radiologist with the Kolebu Teaching Hospital. I have no disclosures. The outline for our presentation is going to take the form of an introduction to MRI of the brain. Take a look at the very basic MRI phases, descriptive terminologies for imaging findings in MRI of the brain. We look at some important brain sequences, and then we'll go through the radiologic anatomy of the brain, and we'll ask ourselves why MRI of the brain. Then we'll conclude the presentation. By way of introduction, these MRI images create a high resolution diagnostic images of the brain using non-ionizing radiation.
Jackson, could you speak a little up, please?
So we talked about
Hello,
the
Jackson.
radio frequencies
Maybe
being
we will speak to the
used
slides.
to excite the protons. So the time for repetition and time to echo describes these processes. So echo time, that's a TE, is a time interval in which signals are measured after the radio frequency excitation. The repetition time denotes the time between two excitations, and as I said, when the magnets aligns the protons, we send in the radio frequency pulse, they get excited, we put them off, they realign or they dephase, and they give signals, then we reapply the signals. So a repetition of all these signals and the pulses is what is going to give us the images. So when you vary the times of the echo and the time for repetition, then you are going to have a T1 weighted image or a T2 weighted image. To get a T1 weighted image, they use a short time for repetition and a short time for the echo. That is roughly below 1000 milliseconds for the TL and 45 for the TE. And for a T2 weighted image, the TR and TE are long. So how do we describe the images that are seen on an MRI scan? The MRI scan can be likened to a map of proton energy within tissues of the body or the brain, as in this case. A variety of the images can be produced which emphasize different tissue types, and in particular those that contain a large amount of fat or water. Unlike CT and X-rays, which can be described as a map of density of tissues in the body, whereby very dense structures are seen as being white, and fluids less dense objects like air and fat are very dense. On the MRI, when we see a high signal intensity, it's going to be seen as being white, and we use the term signal instead of density. If there's intermediate signal intensity, that means the structure normally will appear green, and in the brain, the reference point is the gray matter, which is the cortex. And if it's dark or black, then the signal is said to be low or hypo intense. So remember, we use signal intensity instead of density as compared to CT and X-ray images. So let's take a look at this CT and MRI images of the brain. Both are centered at the level of the corona radiata, or the body of the lateral ventricles. So to the image on our left here, we see that we have a shape
Jackson, is there
of
anything that can be done on your audio? The audio is on and off, and it's also very low.
Let's look at
People
some
finding difficulty
image
following.
sequences. And as I said, these can be varied to give protocols depending on the indication of the MRI. So basic ones, you have a T1 weighted, a T2
Jojo,
weighted,
can you make the presentation live?
Sequence. You have the DWI, the ADC, and we'll
Emmanuel
look at the GRES
Jackson.
WI. We'll go through the full
Okay, maybe you can
names.
present live?
Post gadolinium T1 images. You can have the MRI.
Please in and let him present
So
live.
look at the T1 weighted images. The T1 images that are acquired by the MRI. We need to know a little bit about the fixes behind it so that we can interpret the kind of signals and images that are produced. In the body are free protons within the various molecules in the body. And we know that majority of the body is made up of water, which has hydrogen ions and other ions that are randomly oriented in the body. So when somebody is placed magnetic field, which aligns all the protons in the body towards the field of the magnet. So it will be in like a north-south orientation according to the magnetic field of the scan. A radio frequency pulse is employed, and this causes the various protons to align, or they are excited. So they are aligned at an angle to the magnetic field. And these radio frequency pulses then cause the protons to spin in phase with each other, creating resonance. When these radio frequencies are shut down, it causes the excited protons to relax, and it gives off a radio frequency signal, which is detected by the MRI scan. When the radio frequency pulse is shut down, the protons will then realign themselves to the original position in the magnetic field of the MRI. This realignment of the protons, coupled with defacing of the spinning protons, that is, they lose use the resonance which they had whilst they were being aligned at an angle to the magnetic fields. These two processes, the realignment and the defacing, is used to generate the signals that we see on an MRI. So a T1 signal will relate to the speed of realignment of the magnetic field. And this happens more quickly when the protons realign. The greater the T1 signal will be. And the T2 relates to the speed of the protons in defacing. The slower the defacing, the greater the T2 signal will be. So this is just a very basic explanation for the MRI images and how they are produced. So we talked about the radio frequencies being used to excite the protons. So time for repetition and time to echo describes these processes. So echo time, that's a TE, is a time interval in which signals are measured after the radio frequency excitation. The repetition time denotes the time between two excitations. And as I said, when the magnets aligns the protons, we send in the radio frequency pulse, they get excited, we put them off, they realign or they dephase, and they give signals, then we reapply the signals. And so a repetition of all these signals and the pulses, so it is going to give us the images. So when you vary the times of the echo and the time for repetition, then you are going to have weighted image.
Okay, good.
To get one weighted image, they use a short time for repetition and a short time for the echo. That is roughly below 1,000 seconds for the TL and 45 for the TE. And for a T2 weighted image, the TR and TE are long. So how do we describe the images that are seen on an MRI scan? The MRI scan can be likened to a map of proton energy within tissues of the body or the brain, as in this case. A variety of the images can be produced which emphasize different tissue types, and in particular those that contain a large amount of fat or water. Unlike CT and X-rays, which can be described as a map of density of tissues in the body, whereby very dense structures are seen as being white and fluids, less dense objects like air and fat are very dense. On the MRI, when we see a high signal intensity, it's going to be seen as being white. And we use the term signal instead of density. If there's intermediate signal intensity, then means structure. When you appear, and in the brain, the reference is the brain matter.
Oh, yes, yes.
Cortex. And if it's dark or black, then the
you are in Faculty of Applied Sciences and Technology.
But remember, we use signal intensity instead of density as compared to CT and X-ray images. So let's take a look at this CT and the MRI images of the brain. Both are centered at the level of the corona radiata of the body of the lateral ventricles. So to the image on our left here, we see that we have a shade of very dark to white or black to white. And if we start at the central portion, you see this paired structure, which is the body of the lateral ventricles, and it contains the CSF. CSF fluid is dark, right? And as we go towards the periphery, we see the gray-looking white matter and the cortex being slightly lighter or brighter than the white matter, which is the gray matter of the brain. And we see this circumferential ellipsoid white density, which forms the skull of the patient. So we said that on CT, the denser the tissue, the whiter the image we are going to see. So less dense, more dense. Okay, all right. On the MRI, we can likewise see the same image of the brain at the level of the body of the lateral ventricles. So the midline structure here, we see some white signal within the lateral ventricles, which connotes the CSF within this space. So we'll say a hyperintense signal of the CSF within the lateral ventricles. Then once we move to the periphery, we appreciate the dark white matter, right, compared to the gray matter at the periphery of the cortex, right? And see that the skull or calvarium, we see that it has the dark cortex, right? Dark cortex, and the diploid space is slightly lighter. Then we appreciate the subcutaneous fat of the skull, which is also bright. So we have hyperintense signal, let's say hypointense signal, isointense signal, and we have another hypointense signal of the calvarium, the cortex of the calvarium, right?
Hello.
So look at some important
Hello.
brain sequences. And
Good morning.
So depending on the indication of the MRI. So basic ones, you have a T1 weighted, a T2 weighted flare or stir sequence. You have the DWI, the ADC, and we'll look at the GRASWI. We'll go through the full names. Post-gadolinium T1 images. You can have the MR angiogram, venogram, the spectroscopy, CSF flow, MR perfusion, and diffusion, DTI, diffusion tensor imaging. So there are more images that we can use the MRI to obtain. So let's look at the T1 weighted images. These are best for neuroanatomy. We are able to look at the anatomy of the brain structures well. So we always employ looking at the T1 weighted images when you are assessing anything within the brain. And the T1 is also best for post-contrast evaluation because of how the relaxation time is on the T1 post-contrast administration. How are we able to tell on the brain which imaging is, if the imaging is T1 or not? So the white matter appears white, that's the areas around the ventricles. They appear white, and the cortex, which is the gray matter, they appear gray. Okay, so there's a popular saying on T1, white is white and gray is gray. Simple, so that you can follow and be able to pick it up. There again, if you can see here, the ventricles, which contains the CSF, is dark. So let's look at some of the structures that appear dark on T1. So we have fluid, which is the CSF, bone, the cortex of the bone here, cases of infection or inflammation, in hyperacute or chronic stages of any hemorrhage. They're also going to appear dark if there are calcifications. Most tumors will also appear dark on T1, as well as hair will appear dark on T1. However, if you see any bright signal on T1, I mean, it's also a clue that you should follow up what this bright signal is to arrive at your diagnosis. So T1, fat, if there's any subacute hemorrhage, right? So anytime you see blood that is hyper intense on T1, you should be thinking it's in the subacute stage, okay? Melanin, the slow flowing blood or thrombus within the blood. If there's a proteinaceous fluid within the sinuses, or there's a postgadolinium image, all these will show us bright signal on T1. And the postgadolinium images, it shows us bright signal on T1 images, and it helps us to detect focal lesions such as abscesses, tumors, metastases. It's employed in the venogram and angiogram of the MRI of the brain, and in advanced cases can be used in evaluating the parameters of MR perfusion. And so we see this image, which is centered in the posterior fossa of the brain, gives the T1 weighted image. And something in the cerebral pontine angle on the left, right, is the pons in the cerebellum. And it's hardly appreciated because it looks so intense to the rest of the posterior fossa structures. Upon gadolinium administration, we see an avidly enhancing lesion in the left cerebral pontine region, which extends into the internal auditory canal at this level. So post-contrast helps us to find lesions that are enhancing, or it helps us to really delineate lesions that have broken the blood-brain barrier. The T2 weighted images are very good for showing pathologies because the fluid contents show as hyperintense signal, right? We see in this image the central ventricles showing the CSF, which are hyperintense, right? The periventricular and deep white matter appear darker than we saw on the T1 weighted image, and the gray or the cortex appears now brighter than the T1 image. Okay, other things that show us dark on the T2 include moving blood, bone calcifications, chronic blood, acute blood, subacute, the early subacute blood, and air. These others are bright, and they include most tumors, infection, inflammation, the late subacute hemorrhage, and fat. Okay, all right. So another sequence that is helpful is the fluid attenuated inversion recovery, which is a flare sequence, and it has both long TR and TE. It's removes the signal from CSF and the fluids, and brain tissue appears similar to T2 weighted image, with gray matter brighter than the white matter, but CSF is dark. Lesions with high water content are better seen on the FLAIR images. There's also T1 FLAIR image, and that shows a high contrast in tissues that have low water content. What are the usefulness of having a FLAIR image? It's important in cerebral edema. If you have a subarachnoid hemorrhage, you're looking at hippocampal sclerosis, tuberous sclerosis for the cortical hematomas, the areas of abnormal metabolism in neurodegenerative disorders, embolic infarcts, chronic infarcts, perinatal hypoischemic encephalopathy, and neoplastic spreads like the glomatosis cerebrae. So we look at this T2 weighted image on my right and the FLAIR image on our left, and we see that we have some hyperintense FLAIR signals in the periventricular deep white matter spaces, and they are appreciated on the FLAIR than on the T2. And take note that you have nulling or removal of the signal of the CSF in the ventricles. So a summation of the findings: if you take CSF, it's dark on T1, bright on T2, and dark on the FLAIR. White matter will appear light on the T1, dark gray on both T2 weighted and FLAIR. The cortex will appear gray and on T1, light gray on T2 and FLAIR. Fats will be bright on all sequences, but less so on the T2 and FLAIR. And if you have any inflammation, infections, demyelination, it will appear dark on T1 and bright on T2 and FLAIR. The diffusion weighted image measures the random Brownian motion of water molecules within the voxel of tissue, and higher cellular tissues or those with cellular swelling exhibit lower diffusion coefficient. So the ability of water to move within the tissues. If there's any disruption, then we say that the diffusion weighted image will show as an increased signal, right? And the diffusion weighted image, or the WI, is normally goes hand in hand with an ADC, right? So the ADC measures the magnitude of the diffusion within the tissue, and this is done by the computer. So the main reason why you have to look at the ADC in conjunction with the DWI is that sometimes you can have a facilitated diffusion or T2 shine through, in which the signal on the ADC is high. However, for us to have a true restricted diffusion, the signal on the ADC should be low. So if you have a higher signal on DWI and there's a corresponding high signal on ADC, then that is just a facilitated diffusion or T2 shine. DWI ADC is employed in ischemic stroke, abscesses, epidermolysis, the groups of CJD, acute encephalitis, and the rest for us to make a diagnosis. Right, so this is an image that shows abnormal collection and the right basal ganglia, and we see this high signal on the DWI with corresponding low signal on the ADC, right? So this is a pyogenic abscess. Okay. There's DWI, ADC, and T2 weighted image sequence in ischemic stroke, whereby after 24 hours, we start seeing or appreciating the abnormal signal changes within the infarctive areas. It tends to increase, and between 7 days to 30 days, we will peak and start becoming hypo intense. The DWI very early on will show abnormal high signal changes and will peak after the 24 hours to 7 days and starts gradually becoming hypo intense in the chronic phases. The ADC will start off by being hypo intense. The region of ischemia will be hypo intense, and after 24 hours will start normalizing and gradually become hyper intense in the chronic phase. So in the chronic phase, we expect that the DWI will be hypo intense and the ADC will be hypo intense. Then we have the gradient recalled echo and susceptibility weighted images. Both of these images are used to detect small amounts of blood products and calcification due to their sensitivity to local susceptibility effects. The SWI is an improved version of the GRE and helps to detect small quantities of blood, be able to tell if it's an arterial or venous vessel, and also be able to differentiate calcifications from blood products. And it's more sensitive than the GRE for looking at cerebral microbleed. So here we have an image. The left image is the SWI, which is the GRE, and we are able to appreciate the multiple hypointense tiny lesions within the brain matter and the cortex compared to the GRE, where the abnormal hypointense signal changes are minimal. Let's look at MRI and the MRV, that's the angiogram and the venogram. We're looking at how we will study the anatomy of the vessels, the arteries, and the veins. A time of flight is commonly used for the MRI because it's fast to obtain the images and we do not need gadolinium. However, they are susceptible to flow phenomenon and sometimes artifacts because of the way the tortuous vessels are, and they create the impression that there's narrowing or stenosis within these arteries. It can be performed by both 2D and 3D techniques, and we can also employ contrast on MRI, and especially when you're dealing with neck vessels and patients that have stents or coils being placed. It's in the era now that we are using the treatment of aneurysms. The MRV also employs both a 2D and 3D technique with the use of the time of flight, and you can have a contrast enhanced MRV, which is less susceptible to artifacts. Now, this imaging of the blood helps us to visualize territories of the brain, look at stenosis or occlusion of these blood vessels, if there are any aneurysm, malformations, or even thrombosis within these vessels. So this is a 3D MR venogram, which depicts and this is the oblique, and this is in the transverse form. We see the superior sagittal sinus, which the cortical veins will drain into, and it forms at the top line. You have the straight sinus, you have the transverse sinus, the right is the left, forming the sigmoid sinus and the internal jugular vein, right? We also appreciate here the vein of Lavi, which drains into the junction of the transverse and sigmoid sinuses. Okay. The MRI, you best appreciate the circle of Willis, right? In which you have the anterior communicating artery joining the ACAs, that's the anterior cerebral arteries. You have the middle cerebral arteries and its branches, which joins the posterior cerebral arteries, right? The posterior communicating artery, which is better seen on this lateral or sagittal view. Okay, so the basilar, which is formed by the two vertebral arteries, then branches into the left and right PCA. Okay, all right. So on this sagittal, you may be able to see the ICA, this anterior portion, this is the posterior portion, right? So you have the ACAs, the MCAs, and you have the PCAs. Let's look at the brain and its planes that we can evaluate the MRI of the brain. So it's important to have a strategic approach to reviewing of the MRI of the brain. Either you go from outside in or inside out. Okay, so the midline structures, then you go out, or outside structures, then you come in, and you keep to this format to help you. Okay, so we have the posterior fossa, where it comprises of the brainstem and the cerebellum. Okay, the white portions we said is fluid, so the CSF we see here, the vermis that links both cerebellar hemispheres. Okay, we're also able to appreciate the temporal bone and the IAC, internal auditory canal, with the nerves, the seventh and eighth nerves going into it. You see the cochlea as a high signal and this two-weighted image. Okay, and as we go up, we appreciate the pons, you appreciate the trigeminal nerves, and this is the middle cranial fossa with the temporal lobes, and we see the folia of the cerebellum. Okay, and anteriorly we see the orbits and the nasal sinuses. Okay, we are able also to appreciate the signal voice of vessels. Okay, so this is the internal carotid arteries as we see it, and we see the small dot as the condylum of the pituitary gland. As we come up, the inferior tentorial structures tend to disappear, and we see more of the lobes. So we have the temporal lobes, and the occipital lobes will be appearing. Okay, so we have the occipital lobes here. We have the midbrain, we have the mammillary bodies, we have the tract here, and is the inferior frontal lobes. So as we keep coming up, we see the lateral ventricles and its horns, and the midline structure is the third ventricle. We see this white matter crossing as the anterior curvature. Right, and we see the caudate head also appearing. Of the caudate head, we have the ventricular nucleus of the putamen and the globus pallidus. Okay, we see the deep white matter being dark on T2. Okay, we appreciate the flow void in the straight sinus. We have the superior sagittal sinus here. We said it's dark on T2, and so the frontal sinuses will appear dark if there are no mucosal or disease in there. Okay, so at the body of the lateral ventricle, we see the lateral ventricles, and as we go up, we see the centrum cerebellum, the white matter. We see the haslope, which is the central sulcus, so the precentral gyrus and the postcentral gyrus, denoting the motor and the sensory strips. Okay, so we go towards the vertex and we see all the extra axial CSF spaces and the forks cerebrae in the midline. The sagittal plane helps us to look from the right to left side, and we appreciate the temporal lobe. The deep white matter is dark. You see the cerebellum and the inner ear structures. Okay, so you move towards the midline, you're able to see some of the lateral ventricles, the cerebellum, and the flow voids that are tubular, mostly vessels. Okay, all right. So the cerebellum is still seen. We are now seeing the body of the lateral ventricles and the deep white matter. Right, as we approach the midline, we see losum, the splenium, okay, all right, then we see the brainstem, the pons, that's his belly here, the medulla oblongata, the midbrain will be at the top. Okay, so we appreciate the stela with the pituitary gland, right? The urticarial cell above it, right? And you have the thalamus, the corpus callosum, the frontal lobe, the parietal lobe, and the occipital lobe. Some of them are secreted by fishes and sonsi. Okay, all right. So we are moving to the other side of the brain. So we see similar structures. Okay, all right, good. The coronal plane, we're able to appreciate the frontal lobe, the olfactory bulb, right? The orbits, the optic nerves. Okay, we appreciate them. And an important structure I want to show you is the hippocampus, okay, which is important in hippocampal sclerosis, so looking for atrophy, any abnormal signals within it. Okay, all right, so the corpus callosum, we look for any midline shifts, effacements of the sulci and the ventricles. We see the pons and the medulla oblongata and the spinal cord. Yeah, so we are moving towards the posterior bit. Okay, all right. So now someone asks, why MRI? Some indications include vascular tumors, infections, inflammatory trauma, hydrocephalus, and congenital malformations. And its advantages? It's non-ionizing. It has multiple planes. You're able to have better soft tissue contrast. There's no concerns about contrast allergy, okay, as in CT, and advanced techniques can help us to improve or see more tissue characterization and different pathologies. Okay, it's limited as it's very expensive and it's not readily available. It has a longer scan time, and there are safety concerns in patients that have certain metal implants, pacemakers, and foreign bodies. It's unstable. Unstable patients cannot undergo an MRI because they have poor images. Okay, and if the person is claustrophobic, you also know incorporating, and there's also a risk of lymphogenic systemic fibrosis in patients with kidney diseases. Okay, in conclusion, it's important for us to have a basic understanding of the MRI phases, which will help in interpretation of these MRI images. A wide range of different MRI images of the brain can be produced to help answer specific clinical questions. A systemic approach is very essential for interpreting MRI brain images. These are my references. Thank you.